Thank you for tuning in. If you are interested in getting further updates on free point-of-care ultrasound education, don't forget to like the video, hit the subscribe button, and ring the bell to be notified the next time I go online or post a new video. This is the POCUS Club channel. It is all about upping your game with point-of-care ultrasound and integrating it into your daily clinical practice. I am Nicholas Lim, an EM and ICU consultant based out of Singapore, and I am going to teach you about the eFAST exam. The comments I've gotten about the eFAST exam when I have gone to perform it are, why are we still doing this exam? It often seems quicker to push the multiply injured trauma patient into the CT scanner and get your answer straight away, as opposed to taking out the probe and putting it onto the patient. Trauma care has certainly evolved over the last 15 years, and quite a few of my colleagues would argue that the eFAST exam is outdated. It has been superseded by this device that has often co-located in the next room over in newly built emergency department resuscitation rooms. Taking out the ultrasound machine during management of a polytrauma patient would sometimes elicit howls and jeers of, "Put that 20th century thing away, don't be doing the eFAIL exam. You will get a much better answer via the donut of truth." Let us dial this rhetoric back a bit. The eFAST exam is still entirely applicable if you are working in a third world country or lower middle income country settings. If you work with Médecins Sans Frontières, like in this case out in Haiti, treatment may be happening out in the back of someone's courtyard. In this case, a patient who has fallen from height with bilateral tib-fib fractures. You have to think, are there any other potential intra-abdominal or intrathoracic injuries that may require further intervention before fixation of the lower limb injuries? A CT scanner is certainly not within easy reach. Coming back to the present day and your local settings, a health service under pressure, ambulances are lining up out the back. There are multiple patients requiring CT when your department just has the one. Who goes first? The polytrauma patient, the patient with a low GCS, or the patient who has had a stroke? Let's take it up a notch. A mass casualty incident with multiple sick patients presenting to your emergency department. How do you prioritize who goes to surgery first, who goes to CT, and who just needs observation for the moment? Let's talk about the people you should perform or you would perform the eFAST exam on. The eFAST was initially described for blunt abdominal trauma, and these patients can be stable or unstable. It was also described for stable penetrating trauma. Unstable penetrating trauma requires surgical intervention, be it abdominal or thoracic. We can use the LLS score to help us delineate the various patients that we might do the eFAST on. This is the looks like shit score. It's a measure of how unwell a patient is, and it is a binary score of 1 or 0. 1 implies that the patient looks extremely unwell and is about to die. 0 means sitting up and reading a magazine. This was described by Scott Weingart in 2013. So let's have a look at this. In a patient with an LLS score of 1, so really looks bad, a negative FAST is not going to be very useful. They are still going to get a CT. Retroperitoneal bleeds, occult bleeds, if the eFAST exam was incomplete. If there was a resource limitation and depending on the response to resuscitation, you might consider repetition of the eFAST, but in all likelihood, this patient is going to get a CT. The protocols at the moment would suggest that a patient with an LLS score of 1 and a positive eFAST should go straight to theatre. But in reality, this is seldom the case. Instead, let's think about positive eFAST in an extremely unwell patient as WWW. The first W, what is the source of the instability? eFAST can help you decide or diagnose pericardial, intrathoracic, or abdominal free fluid, in this case blood. So It can help you decide whether you want to call the surgeons, the general surgeons, or the cardiothoracic surgeons. It also allows you to time the procedure. So for example, do you need to prioritize a pericardial drain, or would you put in a chest tube, or does this patient need to go to theater for laparotomy? So you can actually time this, and when these things you can prioritize these to see when they actually need to happen. And then the final W is where. Where does this patient's disposition lie? Are we going straight to theater? Are we going to go to CT and then IR? Or are we going to be watching this patient and see if they respond to resuscitation and then take a decision later on? With an LLS score of 0, you can, even though the eFAST exam is described as not a rule out, and I would recommend that you do not use the eFAST exam in the first instance to rule out abdominal or intrathoracic pathology. However, it can certainly reassure you that as the clinician, that there's not a whole lot going on with the patient for the moment. If the eFAST was positive, you may consider watching them or admitting them for observation or a CT. In the case of a patient where, they are not very sick, they have all earned a CT because of the mechanism of injury. But performing an eFAST exam at this point on this patient can help you triage the patient and decide how quickly this might need to be done and who to prioritize, especially if you work in a very busy emergency department. So let's talk about how. How are we going to do the eFAST exam? The eFAST exam, initially it was just a FAST, which is a combination of the right upper quadrant, the pelvis, and the left upper quadrant. E was added to this, extended, which includes the assessment of the thoracic cavity for pneumothorax, and pleural effusions in the case of trauma would be a hemothorax. The order that I would do this in, and this is the order of sensitivity, would be the right upper quadrant, followed by a longitudinal view of the pelvis, and then the left upper quadrant. The thoracic section of the pericardium and the pneumothorax and pleural effusions, this order can change. You can do this first, especially if the patient came in with signs suggestive of intrathoracic injury, or if there is a seatbelt injury or something like that, then you may consider doing the abdominal component first. So let's look at the right upper quadrant. The right upper quadrant is performed with the curvilinear probe placed in the right upper quadrant. What you should see is this. So we are particularly interested in the Morrison's pouch, okay? This delineates Morrison's pouch. Notice how the examiner or the person performing the eFAST exam is actually fanning through the organs. This is a really key point and a really important point. We are not just looking for single still images. Scanning through the entirety of the organ is very useful, and I'll show you this in the next couple of slides. So have a look here. This is another image, and you can see how it is slightly different in that there is some free fluid in the right upper quadrant at the inferior pole of the kidney. Fluid can certainly accumulate here first. It can accumulate at the caudal tip of the liver, and then it kind of tracks down into this little triangle here between the kidney and the liver before it actually goes into Morrison's pouch. So those are areas that you really need to clear. Over here, this is the right paracolic gutter. You can see there's quite a lot of free fluid in the paracolic gutter at the caudal tip of the liver. There doesn't seem to be as much around the kidney and the liver in Morrison's pouch, but certainly very, very positive there at the caudal tip of the liver. Next one, okay. Again, the importance of fanning through the organ. So over here, may not see some, you may think initially that there wasn't much free fluid, but when you fan through the organ, you can see, look, there's some free fluid there at the caudal tip of the liver. Okay, over here, very positive eFAST. And for the people who are more familiar with this examination, you can see that there is something going on above the diaphragm as well. And this would suggest a pleural effusion, and in the case of trauma, it's probably hemothorax from inferior mammary artery, or it could even be the arteries that run between the ribs. Another really positive eFAST here. You can see fluid all the way into the Morrison's pouch. Okay, now next one, pelvis. So you need to go quite low with this, okay, and you need to be perpendicular to skin. So this image not so good. I would like to do this more in the longitudinal view as well, as opposed to doing this as a transverse. Let's have a look at this. Okay, so here you go. So this is the bladder, and you can see that there's no free fluid, and you want to look in the posterior areas here. So if it's female, you're looking in the pouch of Douglas, and the males, you're just looking into the retroperitoneal kind of bladder area. Okay, so in this case, no free fluid. Okay, again, demonstration fanning through the organ. Over here, you can see looks like multiple layers, but there is free fluid over here. Okay, just see the bladder over this side. Okay, and you can see free fluid over here. Okay, this is in the transverse. At a later clip, you can see in the transverse section, there is free fluid all around here. Okay. Now over here, you can see female uterus in here, and you can certainly see free fluid here in the pouch of Douglas. Okay, another one, more free fluid you can see over here, all right, posterior to the bladder. And over here, a gross amount of free fluid also in the posterior section of the bladder, just over here, okay? Now, left upper quadrant. So the left upper quadrant is almost the last component of the abdominal eFAST exam. And the reason for that is that the space is really tight, and you need a lot of free fluid before the left upper quadrant actually becomes positive. So much so that I've treated a lot of patients with where they've actually ruptured their spleen, but the eFAST is actually negative in the left upper quadrant and really positive in the right upper quadrant. This in this case, make sure that you are really low, okay, or really posterior. So your hand almost needs to be touching the bed, and the probe often needs to be higher or towards the head. So the mantra with this particular area is to the head and to the bed. So probe needs to be almost in the bed, and you need to shift it higher towards the head of the patient. Okay, so this is a normal looking eFAST. Free fluid tends to appear in the space between the diaphragm and the spleen, as opposed to the space between the spleen and the kidney. And the reason for that is that the splenorenal ligament is a really tight ligament, and it keeps these two organs very closely together. There needs to be a lot of fluid before you will see that positive, and you will often see fluid above the spleen first before you see fluid between the spleen and the kidney. So let's have a look at this. You can see here, small amount of free fluid here. Okay. This is obviously quite a lot of free fluid. So you can see free fluid here, the spleen is here, and this is the stomach. Okay. Here again, very positive, and you can see here how there is not very much free fluid here in the splenorenal space, but lots and lots of fluid between the spleen and the diaphragm. What do you think about these images? Do they look negative or positive? Or I suppose the third answer is, is there not enough information? In this image, you may think, right, there's nothing in Morrison's pouch. Over here, you go, yeah, that looks pretty okay too. But make sure you fan through the rest of the organs. Make sure you fan through the rest of the organ. Make sure you clear the caudal tip of the liver. Look especially in this space here and in the paracolic gutter in the right upper quadrant. Free fluid tends to occur over here before it tracks into Morrison's pouch. The same over here, look at the paracolic gutter and the caudal tip of the liver before you call the space clear. So several pitfalls that we discussed here. The order that I prefer to do it in is right upper quadrant, pelvis, and left upper quadrant. clear the spaces. If the space is positive, you don't have to do the rest of the examination. The eFAST is positive. You have to decide on what you want to do next, be it to surgery, be it to the theater, be it to a CT scanner, or are you going to line up your IR folks? Now, let's talk about the thoracic space. So pericardium first. The pericardium can be imaged with either the curvilinear probe or the phased array probe. Have the probe just inferior to the xiphisternum, push down. You may need to hold your probe slightly differently in order for you to be able to tilt your probe as low as that. Now, what you will see is this. Okay, so this is the liver. This is the right atrium, the right ventricle, the left ventricle, and the left atrium. You are particularly looking for this area around here, and that's the pericardium, and you're looking to see whether there's any free fluid or fluid in it, which shows up as black. Okay, that is an indication of tamponade. You can see how the RV, even though there is a very small pericardial effusion, how the RV is actually collapsing, and it almost seems like a man jumping on the right ventricle. You can see that it's not filling. This is the true physiology of obstructive shock. There is no forward flow of blood. This is a much larger pericardial effusion. You can see how the RV is collapsing. The RA is also collapsing. If you did an ECG on this patient, it will probably show electrical alternance, where the QRS complex is alternating between a positive inflection and a negative inflection. This is quite a large pericardial effusion. And if you have still difficulty visualizing how tamponade looks like, think of John Travolta and him in that Saturday Night Fever. See what the RV free wall is actually doing. This is another potential pitfall. You need to check the space here, because sometimes if it's traumatic and clot is starting to form in the pericardial space, it can appear gray and look like tissue. In actual fact, this is clot, and this is fresh blood, I'm assuming. Something like this would make you a lot more wary. And over here, you can see quite a large amount of clot, quite a large amount of pericardial clot. The RV is almost non-existent. The LV is here trying its hardest to fill. Next one then, pneumothorax. Depending on whether your patient is supine, and most trauma patients will probably be supine, you would probably want to start on the anterior chest wall. And what you are looking for is, you are looking for the pleural line. Okay, make sure that the pleural line is below the ribs. Okay, so you can see here movement sliding. Okay, and you can see there's an A profile. Okay, A profile sliding, no pneumothorax at that point. Move on. Now, comparing like for like, so what does a pneumothorax look like? So this is on the left side of your screen, there is no pneumothorax here. You can see the lung sliding. This is the visceral parietal pleural interface. Okay, and you see that sliding, there is no pneumothorax at that point. Over here, you can see up and down movements of the chest wall, but the pleural line is more or less static. There is no side-to-side movement of that, and this would be highly suggestive of a pneumothorax. What you see over here is a pleural line, okay, the visceral parietal pleural line, and this area is not moving. So this is what we call the lung point, just over here. Okay, this is where the visceral and the parietal pleura are separating from one another. What do you think about this image? What do you think about this clip? Is there a pneumothorax or not? Okay, so you may see this white shiny line here. It seems to be moving left and right. It's bright white and it seems to be moving back and forth. Okay, but we are not sure where this line is. Okay, so if we scan a little bit more, we'll see that this bright shiny line is actually above the ribs. Okay, so you can see here the ribs, and this is the shadowing, posterior shadowing from the rib. And you can see the true pleural line is over here, and it doesn't seem to be very much movement at all. this would be very highly suspicious. This is most likely a pneumothorax. And this bright white line here is surgical emphysema. Be very careful. Make sure that you localize your pleural line to below the ribs. Okay, other pathology that you will see in the pleural space is a large pleural effusion. Okay, could be blood, could be, depending on the context again. This is a left-sided pleural effusion. Okay, and you can see the heart in the background and quite a lot of contused lung as well. So everything we do, we always talk about evidence-based. What is the evidence for the positive eFAST? So if we had free fluid in the abdomen, what is the likelihood of intra-abdominal injury? Okay, so if we line this all up, so positive eFAST, you see your positive likelihood ratio is 30, which is great. A negative likelihood ratio of 0.26. In a sense, 0.1 of a negative likelihood ratio, if it's less than that, you can rule pathology out. A positive likelihood ratio of more than 10, you can rule pathology in. The eFAST is very good for ruling in, and that's why we say it's not so good for ruling out. Pneumothorax here, so positive likelihood ratio of more than 50, and negative likelihood ratio of 0.09. So good enough to rule in, good enough to rule out. So let's do some take-homes here. I'm coming to the end of my talk. The eFAST is a rule-in exam when you first start out, but certainly in patients who are quite stable, and when you scan them and there's no free fluid, you can be a little bit more at ease. The exam is simple, repeatable, and possesses minimal risks for the patient. There is no radiation risk involved with this. So, you can certainly repeat these exams. You can change the order in which you want to perform this examination. For example, if the patient has evidence of thoracic injury, you may want to start in the thoracic component of the examination first, as opposed to doing the abdominal, then the thoracic. Make sure you clear the spaces properly. So, for example, right upper quadrant, inferior pole of the kidney, paracolic gutter, the caudal tip of the liver. Make sure you look at those areas before calling the scan negative. Fan through the organs in their entirety. You are only taking a 2D image of a 3D structure. So make sure you clear the whole organ. And again, if there are any questions, you can always email me or tweet me at POCUS Club. Thank you very much.